Dear colleagues, in partnership with the Deutsche Gesellschaft für Nephrologie, the Österreichische Gesellschaft für Nephrologie, and the Société Francophone de Nephrologie, Dialyse et Transplantation, Marcus at Home welcomes from west to east, from the Pacific Ocean to the North Sea, Dr. Ricky Turgeon in Vancouver, British Columbia, Dr. Scott Garrison in Edmonton, Alberta, Dr. Swapnil Hiremath in Ottawa, Ontario, all in Canada, and Dr. Isla Mackenzie in Dundee, Scotland, UK, in order to discuss whether antihypertensive drugs should be prescribed as morning or evening pills, focusing upon 3 landmark trials on this topic, TIME, BedMed and BedMed Frail, and their subsequent meta-analysis, which, when taken together, substantially question the seeming evidence from 2 former Spanish trials in the field. So a very long introductory sentence on a very important topic. Therefore, dear Isla, Swapnil, Scott, and Ricky, we are very honored to host 4 global leaders in the field of hypertension research.
Ever since the HYGEA chronotherapy trial was published in 2020, there has been debate over whether patients truly benefit when taking their blood pressure medication at nighttime versus in the morning. We're very happy to welcome 4 guests tonight who have conducted large-scale trials on this topic within the past years and have dealt in detail with this question. First, we welcome Swapnil Hiremath, who is a nephrologist and associate professor at the University of Ottawa and the co-founder of the online journal club NephJC. He will set the stage on the implications of past and current trials and the future of blood pressure medication timing. Next, we welcome Isla Mackenzie, who is professor of cardiovascular medicine and honorary consultant physician at the University of Dundee and Nine Wells Hospital. She will present the TIME study, which addresses cardiovascular outcomes in adults with hypertension with evening versus morning dosing of usual antihypertensives in the UK. It was published in Lancet in 2022. Our third speaker tonight is Scott Garrison. Professor Garrison is a family physician with a PhD in experimental medicine at the Faculty of Medicine at the University of Alberta. He presented the results of the BedMed and BedMed Frail trials this year at the Congress of the European Society of Cardiology. The studies address bedtime versus morning use of antihypertensive for cardiovascular risk reduction. Last but not least, we welcome Ricky Turgeon, who's assistant professor at the Faculty of Pharmaceutical Sciences at the University of British Columbia, and will present a systematic review and meta-analysis of all the currently available studies in this space.
Thanks again for having me. Unlike the August trialists that are there in the audience, I'm just someone who's got a lot of opinions in this topic, and I have done more of critical appraisal of the existing literature rather than do a trial. And I'm really happy that TIME and BedMed were done to disprove and show what was not really right. But let's go back just for our audience to understand why are we even talking about this. It's been known in the hypertension world especially that nocturnal blood pressure is bad. Nocturnal hypertension is bad. So this was one analysis. It was a consortium which looked at multiple observational studies, and they pooled it all together. And this shows the impact of the absence of nocturnal dipping. So normal circadian rhythm is such that the blood pressure drops at night when people are sleeping. But if that does not happen, this is what you will see. You will see roughly a 40 to 50% increase in MACE or a 40% increase in cardiovascular mortality. Note, this is observational studies. And this was a subsequent much larger analysis done from the Spanish ABPM study, which showed that the, again, even if you adjust for daytime and clinic blood pressures, this 1.45 is the increase in mortality that was seen in patients for 1 standard deviation higher nighttime blood pressure. So again, this is a very crude way to put it, but if the hazard ratio for worse outcomes with nocturnal hypertension is on the order of 1.4 to 1.5, if you're able to completely take that away, okay, which may or may not be possible, the reciprocal of that is about 0.67. So that's the kind of effect size you may get if you're able to completely take away nocturnal hypertension and restore the normal nocturnal dipping. But is that even possible? So non-dipping pattern is not just because of medications. It's often caused by it's often seen in patients who have diabetes or chronic kidney disease. But we think, volume overload, obstructive sleep apnea, increased sympathetic activity, those are the kind of pathophysiologic mechanisms which lead to nocturnal hypertension and non-dipping pattern. And, the Spanish trials, the HYGEA and MAPIC and other trials, they reported that just flipping the medication time from morning to bedtime would, completely take away this contribution of nocturnal hypertension, it's really hard. Even before we go into the trials that we are going to discuss today, it's really, really hard to think that changing this medication timing will do it. The other reason is that this was another meta-analysis which looked at the timing of the effect of time of day of administering pharmacological agents and the drug half-life. It would make sense that there would be an effect of timing if the drug has a short half-life, right? So you see towards the in the 0 to 0.5 or 0.5 to 2 drug half-life, those are the drugs with short half-life where timing does matter. But for drugs which have a long half-life, it doesn't matter. So for example, this is hydralazine, which has a short half-life. So if you're using hydralazine, yes, it matters whether you give it in the morning or the afternoon or the evening. And ideally, it's a 4 times a day drug. Or for captopril, for example. But in modern treatment of hypertension, we don't use these short-acting agents. We use long-acting agents, which act over 24 hours, 36 hours or longer. So you should not expect to see any effect, whether such a dramatic effect if you give it in the morning or the evening. So it never made sense that just giving drugs at bedtime would have a dramatic effect on clinical outcomes, which was sort of when these Spanish trials came out, we all looked at it with a very skeptical eye, saying, the effects don't seem very plausible, and we need better, larger trials, which we'll hear about now.
Thank you very much for this great summary of all the accountable factors that need to be considered. I'd like to introduce Isla Mackenzie to present her data on the time trial.
Thank you very much for inviting me to present on the time study. So we ran this study from the University of Dundee, and the principal investigator was Professor Tom MacDonald, but I was also involved in the trial throughout. So we asked the question, does antihypertensive therapy taken in the evening result in improved cardiovascular outcomes compared with morning dosing? So this was a prospective, randomized, open-label, blinded endpoint design trial, and it was fully decentralized in that we did not have in-person visits with the participants. We had 21,104 randomized participants in the trial. The primary outcome was MI, stroke, or vascular death. And this study was funded by the British Heart Foundation and also supported by the British and Irish Hypertension Society. So our participants signed up online at a bespoke site that we had created. They were randomized to start taking their usual antihypertensive medication in the morning or the evening, and then they were followed up over a number of years for cardiovascular outcomes, which we collected by record linkage, but also supplemented by reference to medical records and GP reports and patient reports. This is the recruitment to the trial. We had quite a long pilot phase while we tested procedures, and then our bulk of our recruitment happened after 2015, where we recruited nearly 21,000 participants within a period of 18 months. So this shows how quickly you can recruit in such a decentralized trial. So we were not geographically limited. We recruited from around the UK. There was no actual clinic appointments for participants. We had central coordination of everything from Dundee. And in our opinion, this led to faster recruitment. It was possible to do this trial with a grant from the charitable British Heart Foundation, and hopefully easier for patients to participate. It was a time to first event analysis, intention to treat primary analysis, and we would need 631 participants with a first primary endpoint to give 80% power to detect 20% superiority of evening compared to morning dosing. The end of the trial was event-driven, and we ended follow-up on the 31st of March 2021, at which time we had 752 subjects with an adjudicated first primary endpoint. So this table shows the baseline demographics of the participants in the time study. So the mean age was around 65. You can see the percentage who were male was just over half. Raised BMI, we had a small proportion of current smokers, around 14% with diabetes, some with impaired renal function, and around 13% with prior cardiovascular disease. And that's the blood pressure at the time of entry to the study. And the primary outcome in the time study, which was hospitalization for non-fatal MI, non-fatal stroke, or vascular death, we saw no difference at all between morning dosing and evening dosing of usual antihypertensives, with a hazard ratio of 0.95. We also looked at various secondary outcomes, including non-fatal stroke, non-fatal MI, cardiovascular death, all-cause death, and heart failure hospitalizations or death. And again, there was no difference between morning and evening dosing for any of these secondary outcomes. We did some pre-specified subgroup analyses for the primary endpoint, and again, we found no differences between the subgroups in the primary endpoint. There was a small effect in current smokers, but numbers were very small. The participants who owned home blood pressure monitors were able to measure their blood pressure in the study, and we could see that those who were in the evening dosing group had lower morning home blood pressures and higher evening home blood pressures compared to those who were in the morning dosing group. So in conclusion, in the TIME study, allocation to evening dosing of usual antihypertensives did not improve the primary endpoint of hospitalization for non-fatal MI, non-fatal stroke, or vascular death compared to morning dosing. We didn't find any evidence that taking medication in the evening was harmful, and we concluded that patients could be advised that they could take their antihypertensives in either the morning or the evening, as the timing makes no difference to cardiovascular outcomes. And because other studies have reported that adherence to medication taking is generally better in the morning, for most people that means that they will probably take it in the morning. So this study was published in The Lancet in 2022, and the new European Society of Cardiology guidelines for the management of elevated blood pressure and hypertension 2024 reference the TIME study in saying that current evidence does not show benefit of diurnal timing of blood pressure lowering drug administration on major cardiovascular outcomes. And it's important that the medication is taken at the most convenient time of day to improve adherence. They should also be encouraged to take medications at the same time each day and in a consistent setting to help ensure adherence. So thank you very much.
Thank you very much for this presentation. Also regarding the ESC guidelines, I didn't know that so far. For the sake of time, I'd suggest that we go through all the presentations first and then discuss all the current data and coming data at the end. So I'd like to ask Scott Garrison for his presentation next.
So thanks very much. I'm going to talk about our two trials, but I'm going to spend almost all the time on BedMed, the community trial. So as it's been said, there were two trials in this space that suggested bedtime was better. The MAPEC trial, published in 2010, had suggested a 61% reduction in MACE. That's what prompted our work. While our trials in TIME were happening, they also published HYGEA, which suggested the same sort of a benefit. So BedMed is looking at antihypertensive timing in a primary care hypertensive population. BedMed Frail is looking at a continuing care population, so a nursing home population. The reason we did two trials is that we knew that frail older adults are poorly represented in most randomized trials, and that the risks and benefits could be different for that group. In particular, since we were hypothetically lowering what was the lowest blood pressure of the day, that people at risk of ischemic or hypotensive adverse effects might be more likely to have them, right? So a population of frail older adults. So in particular, we wanted to look at things like falls and fractures, decubitus ulcers, sort of pressure sores, and worsening cognition or worsening behavior problems in that group, which is related to cognition. So again, I'm going to spend most of the time on BedMed. It was an open one-to-one parallel probe design. We were initially, it was event-driven, looking for 406 primary outcomes, which was the largest number of outcomes we thought was realistic for us to achieve with a network our size over the grant horizon that we were applying for. As the trial was running, there were fewer patients being recruited out of each practice than we had anticipated. We initially lowered the event rate for stopping to 255, which was the number of events in MAPEC. But our funders came through and allowed us to observe longer. We maximized that and ended up with 336 primary outcomes at the end of the trial. We recruited from spring of 2017 to spring of 2022 and followed patients until the end of 2023. Recruitment was out of 5 Canadian provinces, so we had 436 primary care providers, almost all of them family physicians, who mailed recruitment packages to their hypertensive patients. We got 3/4 of participants that way. We also had a social media campaign happening in the same provinces, which picked up another 25% roughly. We had administrative health data linkages for about 93% of participants. The only ones we didn't have that for essentially were the residents of Saskatchewan and Ontario, which were not comfortable sending patient-level data across borders. So outcomes came from patient report and from administrative health data tracking everybody in our healthcare system. The inclusion criteria, you had to have hypertension, at least one once daily blood pressure med. You had to be living in the community and an adult. We excluded you if you had a diagnosis of glaucoma. The reason for that is that there is an association between lower overnight pressures and optic neuropathy, sort of sudden worsening of vision in patients with glaucoma, for which ophthalmologists have said we should not use blood pressure meds at bedtime. And we excluded you if you had sleep disrupting shift work. That resulted in patients that were 67 years of age on average, 56% were female, 94% were white, 17% had diabetes, 10% had coronary artery disease. Half of them were on monotherapy, and it was pretty evenly distributed between ACEs, ARBs, calcium channel blockers, and diuretics, less so combination pills and beta blockers. Intervention was taking all once daily blood pressure medicine when getting ready for bed. Control was taking all once daily blood pressure medicine upon waking in the morning. So allocation was obtained while dialoguing directly with a research assistant who was using the REDCap server's central randomization module. So in ensuring irreversible and concealed allocation. We followed patients up at 1 week, 6 weeks, 6 months, every 6 months thereafter. And we had a blinded adjudication committee that examined both the patient reports and the administrative health data and sought further information from family physicians if there was either a discrepancy or if we only had information from one source in order to corroborate it. Primary outcome was all-cause death or hospitalization or emergency department visit for stroke, acute coronary syndrome, or heart failure, which I'm going to refer to as MACE. I realize that conventional MACE definition now is cardiovascular death. At the time we did this study, again, we were mimicking MAPEC, and MAPEC had all-cause death in its composite, and had shown a difference in all-cause death, as did IGEA show a difference in all-cause death. Secondary outcomes for each component of the primary: all-cause unplanned hospitalization or emergency visit, and the safety outcomes were ones that were postural hypertension related, so falls, fractures, lightheadedness, vision-related ones, new glaucoma diagnosis or self-reported worsening of vision, and cognition-related ones. So cognitive decline at 18 months, which we measured with something called the short blessed test, which is kind of like a mini mental status exam, but you can do it over the phone, which we did at baseline and again at 18 months. New impairment consistent with dementia, which was a bad enough score at 18 months, or a new diagnosis of dementia in the administrative claims data. And nursing home admission, which in Canada is driven by dementia. So we randomized 3,357 patients. Only 3% either withdrew or were lost to all follow-up. An additional 16% over the 7 years or so that this study ran, an additional 16% were lost to active follow-up, but we were still able to follow them electronically using the administrative claims data. They were followed for a median of 4.6 years. The primary analysis is intention to treat. As far as adherence, 83% of once daily blood pressure meds were taken per allocation in the bedtime group and 95% in the morning group at 6 months. And you can see the breakdown. So the green indicates drugs that were taken per allocation. The orange is if they're taken on the opposite allocation, and the yellow is that's taken twice a day. So you can see good adherence for ACEs and ARBs, also for calcium channel blockers. Where it fell apart was with beta blockers. A lot of beta blockers are used twice a day in Canada, and most of the family physicians were leaving those untouched. And then diuretics. So either diuretics on its own or combination pill in Canada means a thiazide with a different blood pressure lowering agent. So if you combine those together, in the bedtime group, 75% of diuretics were taken at bedtime. We previously had published, there was compared to people switching a non-diuretic to bedtime, if you switched a diuretic to bedtime, you had a 14% absolute increase in feeling that nocturia was a major burden. But generally speaking, people are able to take diuretics, thiazides, at bedtime. So did it make a difference? I think you know by now it did not. So we had 163 events in the bedtime group, 173 in morning. The adjusted hazard ratio was 0.96 with a p-value of 0.7. It really didn't matter how you split up the primary outcome. We had tons of different ways we looked at it by sex or by age, frailty measures, comorbidity measures, what drug you were on. None of it made any difference. Neither was there any difference in any of the outcomes that we were looking at. In particular, the safety outcomes were no different. So postural hypertension related ones, falling fractures, no different. New glaucoma diagnosis or worsening of vision, no different. Measures of cognition, no different. The BedMed Frail. So just in the interest of time, again, I thought you just wanted me to talk about BedMed, but so BedMed Frail, it took place in 13 facilities, continuing care facilities within Alberta, 17 different wards within those facilities. And we randomized 776 people, same morning versus bedtime. And the primary outcome was exactly the same, all-cause death plus those hospitalization for acute coronary syndrome, heart failure, or stroke. But we had different safety outcomes that we were looking at, and I mentioned those, some of those to you in the beginning. And the basic result of this is the same as BedMed. So the hazard ratio was 0.88, p-value was 0.28. One thing I should point out is that in this group, this is driven largely by all-cause death. About a third of these people die every year. So we certainly can say there's no difference in all-cause death. And we can also say that there was no difference in any of the safety outcomes that we were looking at. So our conclusion is essentially the same as time, that it seems perfectly safe to take blood pressure medication at bedtime, but there appears to be no additional cardiovascular benefit conveyed from doing so. And so we believe you should take blood pressure medication whenever you're least likely to forget it or easiest to take it.
Thank you very much, Professor Garrison. Very impressive study results. Next, I'm looking forward to Professor Turgeon presenting his results in a meta-analysis, including all the currently existing evidence on this topic.
Thank you. So I'll primarily be talking about the meta-analysis, and I'll cut to the chase because our presenters have already described a lot of the background and introduction around the concept of this, or the idea behind this meta-analysis. But essentially, we conducted a systematic review and meta-analysis of these blood pressure lowering medication timing trials. And the reason we did that is because the timing was right. At the time that we designed the systematic review, the BedMed and BedMed Frail results were not yet known, and we knew that they were coming. And so we worked with Dr. Garrison at the time, and my PhD student Blair on essentially performing a systematic review on this topic and identifying all of the trials, including the ones that we talked about, but we also went to look to see if there were other investigators, even smaller trials, that had evaluated this question. And I won't go into all of the specifics on this slide, but two things that I want to highlight. One is the fact that we really focused on the trials that compared timing of a drug at bedtime or evening to the morning, because we know that there's some trials that are out there that have looked at one drug given in the morning to a different drug given at bedtime. And that's a very complex comparison. There's multiple points despite, beyond the timing aspect of it. And so we excluded those kinds of trials from this analysis. The other point that I think is important to mention is that we, like in any good systematic review, we performed a risk of bias assessment. We did so using the Cochrane Risk of Bias 2 tool, which is fairly objective or prescriptive in terms of its assessment. And the two people, myself and aforementioned Blair, are two people who were completely uninvolved in these trials, had no duality of interest around this, and nothing to gain or lose from rating the risk of bias of these. So feel that these are fairly objective assessments of risk of bias. So we focused on outcomes that our other presenters have talked about. We focused our primary outcome to a definition very consistent with that of BedMed and BedMed Frail. So composite of all-cause death, myocardial infarction, stroke, and heart failure exacerbation. These are fairly typical composites for hypertension trials, although aforementioned, Dr. Garrison mentioned that all-cause death, cardiovascular death, as I'll show, it doesn't really matter how you define it. Our secondary outcomes were all of these as individual components and the safety outcomes that Dr. Garrison mentioned. So fractures, glaucoma-related events, worsening cognition, all things that could theoretically be worsened with bedtime or evening administration or causing nocturnal hypotension. I won't spend too much time talking about all of the nitty-gritty of the analysis, but we essentially primarily focused on a very traditional meta-analysis, frequentist framework, trial level, hazards ratios all pooled together. We knew that there was going to be some heterogeneity between these studies, so we used a method that was very conservative in that sense, that accounted for all of the potential heterogeneity across these different trials. And we specifically looked at risk of bias as a potential cause for that heterogeneity. We conducted some secondary analyses that I'd be happy to talk more about, but essentially what we did is we had obtained individual participant outcome data from Dr. Garrison for BedMed and BedMed Frail. And for the other three trials, what we did is we extracted and reconstructed patient-level data from the Kaplan-Meier curves that were published for the outcomes that were published. We also did Bayesian meta-analysis, which I'll touch on a little bit briefly, using only the data available. So it was a vague prior-based Bayesian meta-analysis. So even though we did a comprehensive systematic review of gray and published literature, we essentially only identified these 5 trials that we've been talking about that include over 46,000 participants. The trials are laid out here, and they've been well described already so far. So for the most part, other than BedMed Frail and its unique long-term care population, these trials were fairly comparable in terms of the big picture design aspects. No smoking gun from a design perspective that would explain differences in results. The baseline patient characteristics are listed here, and so weighted across all 5 of these studies, the mean age was 63, 55% were male, 94% plus were white or Caucasian. About 12% had prior cardiovascular disease, 19% had diabetes, and the trials that reported it, patients were taking an average of 1.5 medications. So most patients were taking 1 or 2 medications at baseline. And so for the most part, this is a fairly representative population of patients with hypertension, particularly those seen in a primary care setting. So as I mentioned, we did a risk of bias assessment, and perhaps no surprise at this point that we identified a clear distinction, or two sort of a dichotomy of risk of bias. We had the described BedMed, BedMed Frail, and time trials, which were at low risk of bias. And then we identify several concerns with the Hygeia and MAPEC trials regarding risk of bias, and particularly the Hygeia trial in the way that it's been described across the different rationale documents and sort of different pieces that were strewn together from various documents. Overall, there's concern that this was not a truly randomized controlled trial and perhaps had a pseudo-randomization or other methodology that we can't really explain because it's not been well described in literature or elsewhere. So overall, we had 2 of these trials that are high or some concern risk of bias. So overall, what happens when you put all of these 5 trials together? Well, the sort of simplistic interpretation would be that there's no statistically significant difference, but there's a lot of complexity hidden in this forest plot. But one of the key things that you'll identify here is that we have our BedMed, BedMed Frail, and time trials, which are very much close to the null. And then we have 2 trials, Hygia and MAPEC, that show potential difference. So that's why it happens when you put these all together, they get washed out and you get a lot of inconsistency or heterogeneity and a very wide confidence interval there. The same thing happens regardless of which of these cardiovascular endpoints you look at. So whether you look at MACE as a composite outcome or the individual components, the same pattern emerges. No statistically significant difference, wide confidence interval, potentially a signal towards benefit because of the MAPEC and Hygia trials, but a lot of heterogeneity between these studies. The safety outcomes were reported not by all of the trials, and so overall the same sort of similar type of pattern of no difference between bedtime or morning dosing of these medications with all of these safety outcomes. Then when you look at the different ways that we've analyzed it, whether we used a frequentist or Bayesian or individual patient data, the results were essentially the same when we look at the point estimate and the 95% confidence interval. So it doesn't really matter how we analyze it. The results are consistent there. What is interesting is that when we look at the risk of, when we analyze things based on risk of bias, there's a clear distinction again there, the results as you would expect with the 2 trials with some concerned risk of bias showing a large effect size, a large relative risk reduction in MACE of 57%. And the trials that are a low risk of bias show really no effect and are very close to the null or no effect. I highlight the Bayesian meta-analysis here not to overcomplicate things, but to potentially help with some of the interpretation. So one of the things that Bayesian meta-analysis is really good for is actually identify what's the probability that something works given the data. And what's the probability that something works meaningfully, so crosses some clinically relevant threshold based on the available data. And so no difference would be 50%, so that would be a coin toss. And 100% would, of course, be certainty that this works. And for most trials, if you were to take a statistically significant trial and translate it into a Bayesian framework, it'd be about a 90 to 95 to 100% certainty that something works based on sort of the conversion. And so in this case, based on the low risk of bias trials, the probability that there's any benefit whatsoever to taking blood pressure medications at bedtime is about 63%. And if we look at a clinically relevant benefit, for example, a 20% relative risk reduction, there's a 25% chance or less that there is a reduction of that magnitude with bedtime dosing. If we were to then try to calculate the probability of a benefit that's more consistent with MAPEC or Hygia, the probability is even lower based on these low probability trials. So in other words, the low risk of bias studies really are not compatible with the effect that we see with MAPEC and Hygia. And so from the meta-analysis, our conclusion was essentially the same as what's been described so far, which is that evening administration of blood pressure lowering medications doesn't really have an impact on major adverse cardiovascular events or the individual components or safety events. And so from a purely outcomes perspective, it doesn't really matter if you take them in the morning or at bedtime. And as has been described from a clinical perspective, it's very freeing because it means you can prescribe it at whichever time best suits the patient, and they can take it at the time that best suits them. But I think the research implications, and particularly what we can say with the Bayesian analysis, is that this concept of chronotherapy and hypertension management really is not supported by evidence, and there's not really much evidence to support continuing to research that concept or try to prove it in this patient population. One more little aspect of that I've added since this ESC presentation. Some investigators out of Europe, led by Dr. Jack Wilkinson, have created this tool, and it's still under development, this tool called Inspect SR, which stands for Investigating Problematic Clinical Trials and Systematic Reviews. And so, they've identified this trend, particularly with, some of the fraudulent evidence that was emerging during COVID, that we need some tools to try to identify smoking guns for trials that go beyond simple risk of bias assessments. And so they've created this tool that works very much like a risk of bias tool that has several domains where you can look at a paper and start to identify potential concerns regarding problems. And these are not problems that assure that these are fraudulent or made up studies, but they do help to identify studies that could be a problem. And if we do, a simple assessment of the HYGEA trial, for example, we can see that there's several domains here where there's at least some concerns. There's an expression of concern raised by the European Heart Journal where it was published within a year of its publication. There's several issues with transparency, and there's some inconsistencies around some of the results that have been presented. So all issues that should lead to pause and should lead to concerns regarding this trial before, thinking of applying it in practice. Okay, that's all I have.
Thanks so much to the four of you. This was really brilliant and a great overview to everybody interested in this field. And I think most physicians should actually be interested in the field because most of us prescribe antihypertensives. I would have one question to each of you. So maybe starting with Isla. The message is actually clear now. It doesn't matter whether we prescribe the medications in the morning or in the evening. Now you came just a few weeks ago with a sub-analysis where you subdivide your participants into, if I remember correctly, night owls and morning larks. And then again, a certain difference re-emerges. Would you just briefly comment upon that?
Yeah, sure. So we did do a chronotype sub-study in the time study. So patients who were still active in the study in about 2020 August were invited to do a chronotype questionnaire and give information on their mid-sleep time and their chronotype using sort of validated questionnaires. And while obviously many people fit in the intermediate range, when you took the people who were really morning people or night people, there seemed to be a lower risk of MI in the time participants, in the people who were morning people who also took their medication in the morning. So it's whether matching when you take your medication with your self-identified or validated chronotype might make a difference to cardiovascular outcomes. We also found that people with a later chronotype had a higher risk of stroke. Now, we've published this earlier this year. The main result of time still remains the same. There's no difference between morning and evening dosing. So this has identified an interesting signal that I think probably needs further prospective work to confirm. So that's where we are with chronotype.
But it might be worthwhile actually to ask our patients, when do you go to bed? When do you get up in the morning? And then if they have no preference to take it either in the morning or in the evening, then one might get an idea upon the best time point based upon this analysis.
Yeah, so I think while it's a preliminary finding that probably needs to be replicated in other cohorts or in a prospective trial, I think it's an interesting finding, and it's the first time this kind of finding has been seen.
Okay. So Scott, then to you as a family physician, do we still need 24-hour blood pressure measurements? Giving all this data, this is for many patients really a pain to take these measurements. They do not really sleep well in the night. Can we stop doing this?
So in Canada, we pretty much just use ambulatory blood pressure monitoring for making a diagnosis. And I would say it's probably the minority of people that have that. We'll usually be using home blood pressure monitors. There might be sometimes, in particular, I probably use it more if I'm looking for hypotension, people wandering throughout the day, if they have some lightheadedness. But virtually never does it get used for management because, as you've just said, anybody will do it once. And a little less than half the people will do it twice, which is I don't think it's realistic to think that it's going to be something for managing blood pressure. I think it does have a role in diagnosis and in looking for hypertension, symptomatic hypertension.
Thanks. Then Swapnil, you as nephrologist, what about patients with CKD 5 dialysis patients? Surely there are no studies on this, and these people have not been included into the large studies. Nevertheless, do you believe that we can transfer these data to our dialysis patients, maybe recommending patients who are in an early morning shift for dialysis taking their medication in the evening, and vice versa, those who are in the afternoon shift taking their medications in the morning?
Yeah, so this in dialysis, it becomes way more complicated because more than the day and night, it's also some drugs are removed on dialysis, and some drugs have a half-life that is way more prolonged because they have got kidney failure. So how should that play a role? So again, admitting with the caveat that there are no randomized controlled trials in this area, we often do use pharmacology to help decide which therapy to use. So for example, some of the only agents which have some benefit is beta blockers, strangely enough, in dialysis. So we use long-acting beta blockers after dialysis, right? Something like say bisoprolol or nadolol, and you give them every other day. So they get it on post-dialysis, and it lasts until their next dialysis. That's some kind of tricks that we use. Other drugs such as calcium channel blockers or ARBs are not dialyzed out at all. So, even if you give them before dialysis or after dialysis, there will be no effect. On the other hand, the aforementioned beta blockers, they will get dialyzed out. ACE inhibitors will get dialyzed out. So if you're having an intradialytic rise in blood pressure, then you don't want to use those drugs. Whereas if you're having a drop in blood pressure, maybe you want to give your drugs after dialysis, right? So those are the considerations that we use in dialysis more than daytime and nighttime. Having said that, the problem of nocturnal hypertension is probably way worse in dialysis, right? Because often they're volume overloaded, and there is some really cool observational data showing that the amount of nocturnal dipping, most patients have dialysis 3 times a week, so Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. But for example, a patient who's having dialysis on Monday, Wednesday, Friday, their blood pressure will drop a little bit on Monday after the dialysis, but on Tuesday, when they're pretty heavy with volume, their blood pressure doesn't drop often, right? So which just tells you that volume is a big component of this nocturnal hypertension rather than timing of drug.
All right, thank you. So my last question, and truly the elephant in the room, Ricky, your data are so convincing, and we still have these 2 early studies published, and one of them in a large leading, actually, cardiology journal. So the first question, which nobody of us can surely answer, what did the reviewers do when they saw the paper? Because nobody of us, I think, could ever believe this tremendous reduction in risk with just switching the medication. But giving your results, are we still content with this just concern that has been raised by the editors? Should this paper not really be retracted right now?
Yeah, I mean, journals are quite powerless at this stage, I think, right? They raise an expression of concern, but it's really up to the academic institution to then perform an investigation, and that is very much behind sort of closed doors and a bit of a black box in terms of what happens at that stage. So I think readers, for us, think there's enough concerns with Hygia and by extension MAPEC that they're not credible, and there's some more credible evidence out there, and the totality of the evidence speaks for itself. But I think it begs the question from a community, from an academic community, how do we address these things when these concerns get raised, and how do we actually get articles retracted or at least have some transparency around some of these issues? A lot of the questions that we have, a lot of the flags that we raised in this systematic review and what I've just talked about, these would be very easily addressed by showing the protocol or even just answering the questions that we pose. Swapnil led the con side of a debate a couple of years ago, a debate paper where we actually expressly raised all of these concerns, and the authors had the opportunity to respond, the Hygia investigators, and chose instead to sort of deflect and bypass that. So, these are things that could be very easily addressed with transparency that is just not there. And we don't have the power to compel that transparency. Only really the academic institution and the journals, when they're doing the peer review at this point, actually have the capacity to do that.
Thank you very much. I only have one question, probably also for Ricky. If you look at all of these things from another perspective, there's probably no real harm in recommending patients taking their antihypertensive medication at nighttime, except adherence is lower, much lower. That's been pretty consistent. Is there any way to statistically calculate this risk versus potential remaining benefit?
I mean, well, we could from a statistical perspective, that's where the Bayesian analysis comes in and can give us a sense of the probability of something working. I guess I would agree with you in this sort of microcosm. There's probably no harm to taking things at bedtime, but I think in a general sort of critical thinking and evidence appraisal perspective, there is harm in us sort of lowering our evidentiary bar and making interventions based on potentially faulty evidence, because I think there's concern that that transfers to things that are potentially higher risk and decisions that may matter more strictly. So I think that it's important for us to, as clinicians, as readers of evidence, to keep that high bar and to require that sort of high level evidence to make changes when it's available, when the evidence is available, of course.
And if I could add, the only thing about the adherence is that when you tell a patient to change their habits, you may not know what's going to happen, right? A priori. When you have a trial and you measure adherence, it's a different story than when you ask patients to change, what their habit and set pattern is for something that is of dubious, if at all, any benefit. Non-adherence is extremely high. We as physicians, as clinicians, we underestimate non-adherence. So you don't want to rock the boat and make it even a little bit worse.
So for us clinicians, the recommendation stands to what's reasonable, and whenever a patient takes it, recommended to take it at that time. Seems everybody agrees here. And I think that's the perfect point to wrap this up. Thank you all very, very much for taking the time to stop by today and giving great presentations on your data. Very big studies, very important studies, and also for the discussion. Thank you very much.
Thanks for having us.